when we see a new patient with myelofibrosis and we identify symptoms in that patient, guidelines and the standard practice would be to treat the patients for symptoms. That would be symptomatic splenomegaly or general systemic symptoms like night sweating, low-grade fevers, itching, bone aches and pains, fatigue, weakness, and others. What do? We typically use Ruxolitinib unless the platelets are below 50 when we use pacritinib. Now, the value of the JAK inhibitors is in controlling those general systemic symptoms or symptomatic splenomegaly by decreasing the size of the spleen, but it's compromised with Ruxolitinib sometimes because of anemia and thrombocytopenia. While we have a guidance how to prescribe and what dose to use for thrombocytopenia, we do not have anything similar for anemia. It's transfusions of red blood cells and then those adjustments as guided by the treating doctor. So we may sometimes get in trouble with low counts, and that may prevent us from getting patients to benefit from Ruxolitinib because of low dosing. And sometimes we see prophylactic underdosing of patients. Patients are given low dose to prevent any worsening of the blood cell count. Well, the report at ASH says that patients with low counts, low platelets or low red blood cell count, actually from analysis of results from the community setting in the United States, appear to do actually well. You can effectively treat the patients with Ruxolitinib based on this data with the good doses, not perhaps 20 milligrams or 25 milligrams twice a day, very high doses, but good doses. And I would say from my own perspective, 10 milligrams twice a day is a good dose where you have a good control of the symptoms and decent control of the spleen. If I can go even higher than 10 twice a day, I would do that. But the message here is that anemia or thrombocytopenia are not detrimental for the use of Ruxolitinib, and we can, based on this data, actually manage patients very well